All right, I'm very, very pleased to introduce Dr. Mike Kim. He's a UW Associate Professor of Neurology at the UW Medical Center and Chief of the Neurology Section at the VA Puget Sound. He completed the UW VA Movement Disorder Fellowship in 2008. So he specializes in movement disorders, general neurology, and botulinum toxin injections. His research interests include REM sleep behavior disorder and the Washington State Parkinsons Disease Registry. Dr. Kim sees patients at the UW Medical Center and at the Seattle and American Lake divisions of the VA Puget Sound. Welcome, Dr. Kim.
Thanks for having me, everyone. It's my pleasure to talk to you about Parkinson's disease and dementia. And what I thought might be helpful to get a better understanding of this very complex condition is to go over the diagnosis as well as go over some of the treatment strategies that we have for Parkinson's disease through a case-based approach. One thing that becomes apparent in people with Parkinson's is that the condition involves both motor as well as non-motor symptoms. Of course, Parkinson's disease came from an English physician, James Parkinson, who lived between 1755 to 1824. If you Google James Parkinson, this is the photo that you'll see. And then for the longest time, I thought that this was in fact James Parkinson. Now, the problem with that is that James Parkinson lived in a time when modern photography did not exist. So that in fact cannot be James Parkinson. So I made that error many times. Of course, he wrote his famous essay on the shaking palsy that we now derive the name of its condition, Parkinson's disease. And we're going to talk about a lot of these symptoms that he describes very accurately, to the most part, in this lecture. Now, James Parkinson, what did he actually look like? It's probably not that important, but there are some pictures and paintings of James Parkinson, and he was portrayed in the society, this English society of providers at this one gathering. So today's objectives, I will be overviewing what is Parkinson's disease symptoms, how do we make a clinical diagnosis, then I'm going to transition to how we would approach Parkinson's disease from a multidisciplinary approach. And then I'm going to focus on various case studies that providers, different healthcare alliance providers can encounter that in terms of the strategy from a medication standpoint, rehabilitation standpoint, exercise, and so forth. This was a study that was published in 2018 by Dorsey and colleagues in the journal JAMA. This was a study funded by the Bill and Melinda Gates Foundation in 2015, excuse me. And this was looking at the global burden of disease of different conditions, including neurological conditions. What they found was that Parkinson's disease, although it's not the most common neurodegenerative condition, Alzheimer's disease is, the rate at which Parkinson's disease, the prevalence is increasing is the fastest. So we can see here from, let me just get my pointer up. 1990 to 2015, we have more than a doubling of the prevalence of Parkinson's disease globally. And as you can see here, the curve is an exponential curve. So 2040, we're going to estimate it to be about 13 million individuals affected by Parkinson's disease. So Ray Dorsey, in a viewpoint in that article, in that journal, coined the term the Parkinson's pandemic, because this is something that I think all of us are concerned about in terms of these neurodegenerative conditions. So patient number one, we have a 65-year-old male who comes to your office complaining of 6 months of gait changes. He also had a tremor of the left hand for 1 year, but never sought medical attention. On review of systems, he endorses loss of smell for the past 10 years. He also endorses weird behaviors at night. His wife jumps in and tells you he has a tendency to kick and punch her at night. He has been doing this for the past 10 years. So here's just a video of this person that I've been following at the Veteran Affairs Hospital for a long time. His background previously becoming retired was that he was a watch repair person. So you can imagine that occupation requires a lot of fine-tune movements. And the video is a little bit grainy, but here, let me just show you what is apparent on the video that I see. So you can see here on his left-hand side, he has a bit of a resting tremor of the left side. It's affecting both his arm and leg. And the tremor, as if I advance the frame, sometimes if you hang the arm off to the side and have him count backwards, then we can also see that the tremor comes out. When I have him position his hands in a postural position, he has a little bit of a tremor there. And then the tremor comes back intermittently in the left hand. Okay, so just tap your thumb and first finger, big taps quickly. Here we're checking for bradykinesia. Okay, try that with the left hand now. You can see on the right hand side, he actually did quite well, but on the left hand side, there's decrement and interruptions. Now go a little slower, but try to maintain big movements quickly as you can. So even trying to focus on the movements, he's still unable to do it very well on the left-hand side. So this is an example of bradykinesia or slow movements. And then on the gait assessment, his gait is actually quite good, except for he has very little to absent arm swings on both sides. And then you can also see on my screen, at least, that he has a tremor of that left arm at rest. So when they're swinging their arms, that's really considered a resting tremor. He's also leaning over to the left-hand side. In severe cases, we call that Pisa syndrome, where they have significant alterations in their posture. So how do we make a diagnosis of Parkinson's disease? Well, there are core motor features that constitute what we call Parkinsonism. Parkinsonism is different than Parkinson's disease in the sense that Parkinsonism is a general feature of people that may have a resting tremor, that may have slowness of movement and postural gait instability. Parkinson's disease is a specific neurodegenerative condition that is a result of loss of dopaminergic neurons that also has these clinical features. A good analogy would be someone with headaches, right? It could be tension headache, it could be migraine headache, but the symptom is I have pain in my head. Migraines is a very specific type of headache. So Parkinson's disease is a specific form of Parkinsonism. Here's a nice picture that depicts many of the motor changes that occurs in people with Parkinson's. You have astute posture, you have arms being flexed. It's actually quite apparent on this picture that there's also reduced. I can see Mike, but I don't see any. Okay, hold on a second. I think I stopped sharing.
Mike, I actually can see your slide, so I'm not sure that's the problem.
Okay, well, I'll just share it again.
Okay.
Is that, Michelle, is that okay? Anyone else can other people not see the screen? It's still black. How about other people?
She said she'll rejoin. Yeah, I think we're all seeing it okay.
Okay, great. All right. Sorry about that. Of course, Parkinson's disease is a multi-system degenerative condition. The main hallmark, of course, with Parkinson's is a loss of dopaminergic neurons. So we can see here on the left-hand side on a midsection autopsy of the midbrain. It kind of looks like an upside-down Mickey Mouse ears. On the right-hand side, we can see this black pigmentation, and that's from neuromelanin. And that is a surrogate marker of how much dopaminergic neurons there are. And if we look over to the right-hand side, we can see that that same area where the substantia nigra, which is the source of the dopaminergic neurons in that pathway, there's a reduction in that neuromelanin suggesting of neurodegeneration. And of course, the pathological hallmark for Parkinson's disease is what we call the Lewy body. Here on the left-hand side, all this pink is called an H&E stain. And we can see here the Lewy body being present in these kind of in the right lower corner of that cell. And then when we stain specifically for a protein that was later discovered to constitute these Lewy body disease, this protein is also known as alpha-synuclein. You can see that the alpha-synuclein is avidly enhancing in that specific area. So the pathological hallmark is, of course, seeing the presence of Lewy body inclusions. Now, this is just a nice cartoon representation of showing that Parkinson's disease is really what we call a presynaptic condition, meaning that the source of the dopaminergic neurons from the substantia nigra is reduced, as opposed to what we call a postsynaptic problem in the blue. So here we can see that the neuron from the substantia nigra to the striatum, which is its projections, is that there is a pretty robust release of dopamine. And then as we progress to, as we progress to loss of dopaminergic neurons, there's progressive loss of dopamine release and less dopaminergic activation postsynaptically. So in terms of just general facts about Parkinson's epidemiology, it affects about 1% of the population over the 65 years of age. Males tend to be slightly more affected than females. And of course, with any neurodegenerative condition, age is one of the biggest risk factors. So as you get older, then there's a higher risk of developing any of these neurodegenerative conditions, including Alzheimer's and Parkinson's. A lot of studies have looked at various potential factors that might be related to increased risk of Parkinson's. Some of them include pesticide exposures such as paraquat and rotenone. Welding, especially if one were to use manganese, can cause a similar condition like Parkinson's disease. And of course, farmers, because of their potential exposure to the pesticides. There are certain protective factors associated with Parkinson's. One of them is smoking, although we don't tell our patients to start smoking, even when they were diagnosed. It is unclear if it's the nicotine, the behavior, or both that's protective. And then caffeine is thought to be protective. And one of the newest Parkinson's medication is an antagonist of this receptor that the caffeine interacts with. And then, oh, sorry, my cat just walked in. So if you see my cat, I apologize. Presynaptic risks includes reduced or absent sense of smell. And that's something that is not specific just to Parkinson's disease. Of course, people with non-neurological conditions can have reduced sense of smell, as well as changes in traumatic causes of sense of smell changes. Here's a nice video of someone with extreme loss of facial expressions. We call that hypomimia.
Hey, can you say, today is a nice day? Okay, could you try ba 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 ba? All right, ba 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 ba. Ta 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 ta.
So she has also, in addition to a complete loss of facial expressions, something called anarthria. She's unable to speak. Micrographia is a condition that is something that we also see clinically. You can see here at 917 the person's handwriting, and they say, "Took Cinemet, this is my best writing. I can't keep writing something large. I actually can't read it. So they took their medication at 9:17, and about an hour, 15 minutes later, you can see how the writing increased significantly to something that would be quote unquote normal. There's a lot of things that can cause Parkinsonism. Of course, a prototype is Parkinson's disease. The most common movement disorder that we see is essential tremor, and sometimes it's actually quite difficult to differentiate between essential tremor and Parkinson's. Other neurodegenerative conditions listed here, like Huntington's disease, Wilson's is not very common, or other conditions like what we call Parkinson's plus or atypical Parkinsonian syndromes can look, at least in the beginning, very consistent with Parkinson's disease. Probably the biggest category that we see in clinic that looks like Parkinson's is drug-induced. So anything that blocks dopaminergic transmission can result in a drug-induced reversible Parkinsonism. Oh, sorry. My cat just keeps coming up, sorry. Here is someone that was evaluated in our clinic for possible Parkinson's. You can see how sometimes it's not as clear-cut between Parkinson's and something like essential tremor. Sorry. So you can see how this person has a resting tremor on the left-hand side worse than the right. And then we're going to have that person put up their arms to check for an action tremor.
I'd have you hold your arms straight out.
And one of his main complaints was tremor with movement. So it looks like if you just saw that, it could look like something like essential tremor, but in fact, we probably thought that he had Parkinson's disease. This gentleman over here was seen in our VA movement clinic. He has a history of schizophrenia. He was on a typical antipsychotic. I can't remember which one it was. It could have been fluphenazine, which is a very potent dopaminergic blocking drug. And he also presented with an asymmetric tremor. One of the questions is it typical for one side to be more affected than the other? And yes, it typically does affect one side first, and then it migrates axially or midline, and then it goes over to the other side. Now, you would think that someone with drug-induced might have a tremor that's present equally on both sides because it should be a global effect. And that's something that we do see. In this person, because the tremor was asymmetric, it's possible that his exposure to the medication, the fluphenazine, precipitated the manifestation of an underlying neurodegenerative condition. And we sometimes see that. Yeah, so to answer one of the other questions, does tremor usually present on one side or the other? It usually does present on one side, and that's very classic for Parkinson's disease. Now, there's a scan called a DAT scan that can help aid in the diagnosis. So if you have someone in your clinic and they're on like high doses or frequent use of anti-nausea medication like metoclopramide, or if they have current or past exposure to a antipsychotic medication, and you just can't tell clinically the difference between a drug-induced versus idiopathic neurodegenerative Parkinson's, you can order a DAT scan. And what the DAT scan is helpful is that it's really good to help differentiate between drug-induced versus non-drug-induced. So on the left-hand side, we can see here this uptake appearance looks like a comma. And that's normal. That's a normal scan. And that could be seen in people with essential tremor, or it can be seen in people with drug-induced Parkinsonism. However, on the right-hand side, the uptake of this nuclear medicine binder is reduced. And it actually has the appearance of a period. And when we see that, that suggests a potential neurodegenerative cause of Parkinsonism. I'm not going to spend too much time on this, but there are some features that may suggest an atypical Parkinsonian syndrome. falls within the 1-year diagnosis. So early falls is something that we typically don't see in people with Parkinson's. If you see that, there might be another reason why there could be falling. It could be due to poor vision. It could be due to an underlying neuropathy. It could be due to musculoskeletal issues, or it could be due to an atypical Parkinsonian condition like progressive supranuclear palsy or cortical basal degeneration. One of the hallmark medications that we use to treat the symptoms of Parkinson's is carbidopa, levodopa. And the response to levodopa actually can help us make a diagnosis that this is in fact Parkinson's disease. There's a rating scale called the Unified Parkinson's Disease Rating Scale that if we see a response or an improvement on medication of at least 30% or more, that has a high specificity in making a Parkinson's diagnosis. So, the atypical Parkinsonian syndromes, they may respond to very high doses of Parkinson's meds in the beginning, but as the disease progresses, the response diminishes. People were asking about, is it common for the symptoms to present on one side? And that's yes for Parkinson's, but if it's symmetric at onset, it's very atypical. It's atypical for Parkinson's. A rapid progression. So if they're really declining fast, think about an alternative diagnosis. So this is a classic video of someone with an atypical Parkinsonian syndrome called PSP, or progressive supranuclear palsy. I'm going to just point out a couple features here. He also has reduced facial expressions, so it looks like Parkinson's disease, and he's checking eye movements. And specifically, he's checking horizontal eye movements. The horizontal eye movements are actually not too bad. However, when he goes vertically, you can see how his eyes don't move vertically at all. And this is what we call the supranuclear gaze palsy, or PSP. And this is very distinct versus someone with Parkinson's. As we get older, up gaze tends to be reduced, but down gaze should be preserved. Makes sense because we need to see where we're going. But in people with PSP, this condition, this ability to look down is significantly altered. I'm just going to fast forward to the gait difference. Typically, people with Parkinson's disease are stooped, and they have shuffle steps. However, people with PSP, if you encounter this in your clinic or evaluations, and you see someone that walks very upright and erect, almost what we call a Frankenstein gait, you can see how this person here looks very different than someone that you would expect with Parkinson's. They're also called messy eaters because of their inability to look down. They can't see the spoon in relationship to the mouth, so their shirts are very messy. You can see here he has a hard time looking at the chair. So switching gears, I think what's really become apparent is the success of the management of Parkinson's disease is really dependent on multiple factors. We have the providers, the primary care specialists, we have rehab providers, we have social work, RNs. All these components make it successful, the treatment of Parkinson's disease. And we all have a role here in how we can contribute to the care for the individual with Parkinson's. In this kind of diagram, I'm showing kind of some of the key components that we tend to focus on in the approach to someone with Parkinson's. We have social community factors. I find it that people with great social support, family support, are more successful than people who are living alone. Education advocacy, that could be due through support groups or care organizations, right? Education is power, knowledge is power. So the more they're knowledgeable of their condition, the more successful the treatment's going to be. This applies to anyone with any risk factors, condition or not, if they're completely healthy. But lifestyle, exercise, diet, I stress this all the time to any individual, whether or not it's migraines, Parkinson's, neuropathy. This is all critical to our well-being. Of course, what we do as neurologists is focus on medications, and there's quite a few medications that we can use to treat Parkinson's, and I will go over some different case scenarios. Rehabilitation services is really key for the successful management of their symptoms, because sometimes the medications are just not very effective for some of the motor symptoms of Parkinson's. I'll give it a good example would be postural gait instability. And the way I like to tell our patients is that when we walk, take right step, left step, and so forth, we don't really think about it. However, with Parkinson's, it almost the individual has to relearn how to walk. They have to develop strategies to overcome some of the issues that Parkinson's causes, such as freezing a gait and balance issues. Surgical options are certainly there. I'm not going to focus too much on that, but I'll show you a good example of someone who had profound benefit after deep brain stimulation. So this was taken from an article recently published that talks about these integrated care network models. And you can break it up into basically 3 main care networks. And all these networks contribute to the individual with Parkinson's. They just have a different focus. So the first network would be your personal network, and this includes your individuals such as support groups, family, and informal caregivers, friends, and families. So that's the personal network. The care network involves the different various healthcare providers. So you got the primary provider, you got the specialists, you got the RN staff that can do a lot of care coordination, and the rehabilitation services like physical therapy, occupational therapy, speech therapy. One of the benefits at the VA is we also have recreational therapy, and we take a lot of advantage of using recreational therapy services to help them maintain a high quality of life. And then we have community network. This includes social workers, medical equipment companies, prosthetics at the VA, financials, counseling and support, as well as transportation. Moving to talking about education and advocacy, there are a number of organizations that can help with education and support. We have many local chapters for the American Parkinson's Disease Foundation. I'm sorry, we have a local chapter in Washington State with many different support groups that are funded and organized by the American Parkinson's Disease Foundation or Association. A more unique local organization in the Seattle area is called the Northwest Parkinson's Foundation. And both of these organizations provide a lot of different educational resources, support group, funding, and support. They have a lot of great information embedded in the website. And of course, we have Michael J. Fox Foundation that can allow someone interested in participating in research, for example, to gain easier access into different research trials. It also provides a lot of great information on the website. As I mentioned, the APDA does have a lot of resources for support groups in the different communities. So I know in like Eastern Washington as well as Western Washington, there's plenty of support groups. We have one at the VA and for the veteran population that's on the second Friday of each month. The medication treatment for Parkinson's disease is quite complex. We have medications treating and targeting motor symptoms. The motor symptoms include tremor, slowness, stiffness, and gait and postural instability. And we also have various strategies and medications for the treatment of non-motor symptoms. That includes depression, anxiety, cognitive changes, sleep disturbances, autonomic dysfunction, which the main one that we see is probably low blood pressure, and gastrointestinal constipation issues. Paracelsus was an alchemist in the Middle Ages, and he tinkered with mercury for treating different skin ailments. And what he realized quickly is that if he gave too much mercury, the person died. So he coined the term, basically, the dose makes the poison. And that's really relevant to a lot of neurological medications because they have benefits, but they also have a lot of side effects. So when we treat someone with Parkinson's, we want to know what is their priority. Are we focusing on the motor aspects? Are we focusing on the non-motor, or trying to do both? We also talk about the balancing of side effects and benefit, right? Because that's important of everything that we do. So going back to this watchmaker, he comes back to you 6 months later with gait changes. And he's had his tremor for the left hand for about a year, but never really sought medical attention. So here's a list of potential medications you can offer to him. Again, he's a watchmaker. His life depends on that. So it may not be that severe in the grand scheme of things, but it's preventing him from working in repairing clocks and watches. So the mainstay therapy that we use for Parkinson's is called levodopa. We have different formulations of levodopa. The most common is going to be this IR, or immediate release. Probably something that's fallen out of favor is using what we call dopamine agonist. An agonist is a synthetic compound that activates the receptor directly. These are effective medications, but because of the side effect profile, people tend not to use them as much. The monoamine oxidase inhibitor class, like selegiline, rasagiline, and the newest one, sulfonamide, is a very well tolerated medication, but it's not very potent. So if you had someone that was on the fence of treatment and they weren't sure they really want to commit to levodopa, then it's fine to start someone like on a monoamine oxidase inhibitor. There are other medications listed here that can help affect better absorption or effectiveness of levodopa. Amantadine is used for what we call the dyskinesias. If you see Michael J. Fox and you see someone who's kind of fidgety, almost like they have chorea, amantadine is a good treatment to consider. Anticholinergic medications were one of the first medications for Parkinson's before levodopa came about, and it's very effective for tremors. And one of the newest one that I mentioned is related to caffeine is the adenosine A2A receptor antagonist, or isodephylline. I think having a schematic cartoon is a good way of understanding how these medications work. So in the yellow is the blood-brain barrier, and certain molecules just cannot easily pass into the brain. The green is the presynaptic neuron, and the pink-purple is a postsynaptic neuron. So dopamine is created through different amino acid precursor, tyrosine, and tyrosine hydroxylase converted to levodopa. So when we give someone levodopa, we're actually giving the precursor or the building blocks to make more dopamine. Levodopa, however, can be metabolized outside the brain into dopamine, and that's not what we want. To block that peripheral conversion of levodopa, we can give something called carbidopa. That's why carbidopa, levodopa are together in one pill. So by blocking that peripheral conversion, more of the levodopa can enter the brain and be effective. So the levodopa enters the brain, and then through another enzyme, the levodopa can finally convert it to dopamine. It gets packaged in the vesicles, and then it's released, and it activates the receptors. Dopamine can be transported back to the presynaptic neuron through this transporter, and then it can also be recycled by glial cells by that enzyme, the monoamine oxidase type B. And that's where that rasagiline and selegiline medication blocks that enzyme. I don't think I can spend too much time talking about this. This is something you can find on YouTube. This is Oliver Sacks, and treating individuals affected by this post-infectious condition called encephalitis lethargica with levodopa. I will just maybe show different segments of it.
Might mean to them. And then finally my hand was forced because so many of the patients were terribly disabled. Some of them couldn't feed themselves. Some of them were dying.
It was 1969, and Sachs was right about L-DOPA. It was like seeing the dead arise. Up they came, up, out of the chairs that had been their prisons.
The first feeling was that it was just wonderful to be alive after being dead so long.
Esther, so frail she couldn't turn over in bed, walked for the first time in 40 years. And Rose, who went to sleep as a coquette, can be heard off camera singing a bawdy song.
If you don't tickle me in the right place, I'll take off my pet.
And then,
So, obviously for these individuals, unfortunately, the effectiveness of levodopa wasn't long-standing. But just to see that brief window of response from the point where, as Oliver Sacks mentioned, like they were from dead to being alive, they were frozen in the state for decades, seeing the world pass by them, but they couldn't interact with the world because they were frozen. And to be able to now finally kind of awaken, I don't know if people saw the movie or read the novel Awakenings, but they're awakened to a completely different generational time. And they're able to experience some of the same things that we all normally experience, being able to move. Here's another video that demonstrates the difference between someone who's off versus on. And you might hear this terms like, are you on or are you off? Because if the medication is not working, they're going to be off. But if the medication is working at its optimal state, they're going to be on. So we hear this individual is in the off phase, meaning that they have a lot of what we call freezing of gait, shuffle steps, and these freezing is really debilitating. It can actually cause a lot of falls and disability. You can see how it's almost impossible for him to turn around, something that we all take for granted in terms of turning. So he kind of bounces around. Sometimes people fight it so much that their center of gravity is moving forward too much and they actually result in falls. So turns, small spaces are the most difficult for people with Parkinson's. Here, going through doorways, that's another area where it becomes really challenging for people with Parkinson's, is that they suddenly always will start freezing. So he's walking, and there's just something about this narrow space that causes them to pause. Actually, he did pretty well there. But again, here turning the left leg in particular seems to be more effective than the right. And it's really difficult for that person to turn around. And then in the next segment, let's see here. Now they're on. Oh, I'm sorry. So they're still off, but what the therapist can do is provide visual cues. So just by the nature of putting these strips on the floor, their walking gets better. Here, they're still in the off phase, but they're providing a auditory cue, like a metronome, to kind of give them some sort of a cadence to help them assist with keeping their walking fluid. But it was almost like they're marching to a beat. And then here's an individual after taking his medications, probably about 45 minutes to an hour. You can see that his walking is definitely more fluid. He still has some periods where it's difficult for them to initiate turns or walking after turns. And you can see here through the doorway, he walks through the doorway like no problem. All right, another complication that we might see in individuals with Parkinson's is what I mentioned to you called dyskinesias. So here we have a 63-year-old female that I've been following for many years as well. She had at this time an 8-year history of Parkinson's, and then she develops these involuntary movements 2 hours after each dose of levodopa. But she has to take the medication every 3 hours. And this is what her involuntary movements look like. It looks like she's fidgety. She's squirming around in her chair. And she's not doing this on purpose. This is completely involuntary. She cannot suppress it. And in the context of Parkinson's disease and taking levodopa, this is what we call dyskinesias or choriatic dyskinesias. Sometimes the dyskinesias can be quite severe to the point where it actually contributes to disability and falls. But I would say most people with dyskinesias are not bothered by the dyskinesias. Here's a nice graph that kind of shows how the response to medication changes over time. Graph A is someone with early Parkinson's. Graph B is someone with kind of mid-stage Parkinson's. And graph C is someone with later stage Parkinson's. And these curves response is related to the plasma level of levodopa. And between these lines is what we call the sweet spot. And the sweet spot becomes increasingly difficult to keep it in. So as you can see here, when the plasma levels goes beyond that sweet spot, that's when they have dyskinesias. Down here at hour 4, it's below the cutoff and which becomes therapeutic, so they're off. And the response becomes more variable as well. Here is a person with young onset Parkinson's who has been experiencing tremors for 4 hours after her last dose of medication. And she takes the medications about every 5 hours. So the medication works for 4 hours, but then she's off for about an hour. And you can see here, she has significant asymmetric tremor, worse on the right compared to the left. And she has reduced movements, reduced facial expressions. The movements are reduced on both sides, but the tremor is predominantly on the right-hand side. So one thing that we do when we encounter these, what we call peaks and valleys, is we may try to shorten the dose interval. So then instead of every 5 hours, they take their medications every 4 hours. The point of medication therapy is to keep them in this kind of what I call, again, the sweet spot, this on period, because if they're spending too much time in the off, that can result in disability. Now, as I mentioned, surgery can be an option for an individual with Parkinson's, and deep brain stimulation is a very effective treatment for Parkinson's disease. Here we have someone who's post-op. So he already had his electrodes implanted. He's wearing the same clothes. On the left-hand side, his DBS has been turned off. And on the right-hand side, I'll show you in a little bit after we turn on the DBS. So again, I've been following this patient for a very long time, since I was a resident, and he had severe tremors affecting his entire body. It's present at rest, and as you can see here, it's also present with posture. And it took me a long time for me to convince him to proceed with the deep brain stimulation, because he was taking his Parkinson's medications every 2 hours, and that's not great quality of life when you have to rely on the medications that are still suboptimal, even taking it every 2 hours. So again, he has the electrodes implanted. It's just that the DBS system is off. Okay, so after we turn on the DBS, you can see how the tremor just basically melts away. He's not on any medications during this video. He's actually been off medications for more than 12 hours. And just by the nature of stimulating a certain part of the brain, and in his case, it's the subthalamic nucleus, the tremors literally just disappeared. And his surgery, I believe, was about 10 years ago, or 8 to 10 years ago. To this day, his tremors are still as well controlled now compared to before. So it's pretty transformational what deep brain stimulation can result in. Someone asks, what percentage of people can go off their meds after deep brain stimulation? We don't tell people to expect that because most of the time, the majority of the time, they need to have some medication on board to assist with the deep brain stimulation effect. Very rarely, someone's able to get off medications completely, but that's like basically unheard of. Most people after DBS continue to take medications. And keep in mind, Parkinson's, as we all know, is a progressive neurodegenerative condition. So what they may be like 5 years ago is going to be very different now. We can certainly make adjustments to the electrodes as well as make adjustments to the medications, but things are constantly evolving in a dynamic process. All right, case number 4, 68-year-old male with Parkinson's experiencing multiple falls per day, despite using his cane and taking his medication. He is taking his medications 3 tabs, so fairly large dose, 4 times a day. And he's also on a monoamine oxidase inhibitor, rasagiline, and pramipexole, which is a dopamine agonist. And this is not this individual, but this is just another individual demonstrating the type of gait changes someone can have.
This
So
patient with
you can see here, similar to that on-off video from the Lancet Neurology, even with using a cane, their stride length is quite shortened. Okay. So typically, initiation of gait is really challenging. Even walking in a straight line, he has multiple episodes of what we call freezing. Turning is what we call the classic unblocked turning, so many steps to turn around. Just random periods of freezing episodes. Okay, so sometimes, why do people get these gait impairments? Well, probably specific to Parkinson's, it's usually due to an under-medicated state, meaning that they're either having off periods or the effectiveness of each dose is not optimal, and we may need to increase the dose. Now, having said that, I would say of the 4 motor features of Parkinson's, tremor, slowness, stiffness, and postural gait instability, this is probably the hardest one to treat effectively. There could be other contributing factors for why they have gait impairment. They may have musculoskeletal issues, right? They may have an underlying neuropathy due to something like diabetes. They may have cataracts or macular degeneration affecting their vision. So all these things can contribute to poor balance. Sometimes increasing the medication dose can result in improved gait function, but not always. So if you try increasing the medications and they don't respond, then we have to think about other strategies. And that main strategy is to get expert therapies from our rehab services, such as physical therapy, for stuff at home, or other stuff we can get occupational therapy and do a home safety evaluation, modifications to their homes, and really try to focus on how to relearn how to walk. Now, the next series of videos are just kind of other types of therapies that we can do to help with gait impairment. One of these things that's been documented to be effective is something called Tai Chi. Tai Chi is a Chinese exercise, I guess, martial arts, which really focuses on meditation and balance.
Okay, so with a bow, what we're trying to learn in Tai Chi is to move with complete relaxation in our bodies. So everything we do is completely relaxed. We learn a sequence of 108 moves. You can't remember all the moves. You just have to do it over and over and over again till your body learns it. It's that whole mind-body connection. We make a distinction between mind and body that perhaps isn't made so much in Taoism, in Chinese religions, in Tai Chi. It takes a lot of practice, but you can retrain your body to not tremor. Instead of thinking about your hand and the hand going to pick up the spoon, think about, as you would in Tai Chi, you open up at the shoulder, then at the elbow. So you take the spoon without any tension, and then you stir, and it works. We should do it with relaxation. Doing this has given me.
So that's Tai Chi. one of the great things about the services provided at the VA is that we can offer Tai Chi services for our veterans with Parkinson's disease. The American Parkinsons Disease Association and the Northwest Parkinson's Foundation also have links to resources or therapists that can offer Tai Chi. There's Tai Chi that can be done through community centers, right? That people can sign up for. Here's another one that gained a lot of attention about, and this is using what we call forced exercise or cycling. And we'll see here why the cycling can be effective.
You would never guess that Judd Stover has suffered from Parkinson's disease for the last 7 years because he doesn't have tremors, he doesn't have muscle stiffness, and his feet don't shuffle when he walks. One big reason he's so active and symptom-free, he said yes to a surprising new therapy.
If you can slow it down even more and better by doing this stuff, and where do I sign up?
What did he sign up for? A clinical trial using a simple treatment.
How you feeling? You're good.
Cycling. Researchers at the Cleveland Clinic are finding that cycling is helping patients stop the symptoms of Parkinson's and can even do something that medicine can't: slow down the progression of the disease itself. Neuroscientist Jay Alberts made a stunning discovery. Cycling can increase certain proteins in the brain that help movement and cognitive function. And so these changes are similar to what happens when they're on medication.
Exactly right. When you have medication, you have an increased activation in this area. You have a similar increase in activation following exercise. So exercise is in fact medicine.
To activate those changes in the brain, patients have to do what's called forced exercise, which means they're working a lot harder than they're used to working. But it's that hard work that gives them the benefits. So to get those benefits, what's the formula? Cycling 3 times a week for 45 minutes at 80 to 90 RPMs.
You know, I don't care what condition you're in. That's pretty strenuous.
That formula has worked so well, Alberts has taken the research out of the lab and into the gym.
The program will return me to normal.
So that's forced exercise, and specifically cycling that could be very effective for people with Parkinson's. Another therapy is something called boxing, or there's a company called Rocksteady that can provide a lot of different therapy for people with Parkinson's. They work on feet and they work on quick movements, but they also focus on speech as well.
Come on, Aaron.
That's my husband, Aaron Latham,
Come on.
with his boxing coach. He and everyone else in the class has Parkinson's.
Give me all you got. Come on. Come on. Boom, boom.
It's a progressive neurological disorder that affects nearly 1 million Americans. You don't hear about very many with the disease getting better.
I think of Parkinson's as being an incredible shrinking disease. It doesn't shrink itself. Parkinson's doesn't shrink. Parkinson's shrinks you.
And I want you to reach up.
Aaron and his fellow Parkinsonians aged 45 to 92 are part of this new program that aims to stop the shrinking, if not reverse it.
Together.
Each exercise works on a symptom.
Then go up. Come on. Give me 10. Up.
Stretching is for their stiffness. Footwork for balance.
Ready? Boom. Come on.
Punching to steady their tremors.
Boom. Yes. Go. Ah!
Ah!
Shouting to counter their soft voice syndrome. And sparring for coordination. So what does boxing do for you?
Boxing is just the opposite of Parkinson's. Everything is designed, instead of to shrink you, everything's designed to pump you up. First of all, you get to put on these great gloves. It gives you enormous giant hands and a different attitude toward the world. You kind of get your physical courage back and your mental courage things to kind of come along.
COVID obviously has affected many different things, and one of the things that COVID affected was the ability for people to do these kinds of therapies, such as rock steady. So I know some gyms have closed down, especially because they're renting out a boxing gym. And, you know, obviously people are trying to stay home initially during the COVID pandemic. You know, I think things are slowly returning back to normal, but it's still not where we were before. Switching gears, I wanted to focus on a little bit more on this next part on non-motor symptoms of Parkinson's. Here we see the essay on the shaking palsy again that James Parkinson wrote. Someone asked about, is exercise helping because it's working the bilateral mind-body connection, or because the exercise allows the brain to process neurotransmitters differently? I don't think anyone knows. It's possible that it's working on multiple levels. One level could be improved blood flow, improved cardiovascular, just overall improved health, right? Another thought is that exercise contributes to reduce inflammation or neuroinflammation. Neuroinflammation is thought to play a significant role in many neurodegenerative conditions, including Parkinson's. So exercise can be thought of as like an anti-inflammatory type of treatment. And I think it also allows for plasticity, right? So, you know, different pathways may be affected chronically with Parkinson's, but with repeated exercise and reinforcements, one can kind of compensate for those areas of difficulties and perform the same thing as well. You know, a good example is with intensive rehab after someone with a stroke. You know, the pathways that was affected by the stroke have now been permanently affected. But with intensive rehab, we know that people have better outcomes. And that's because we are employing and the ability for the brain to have plasticity. So going back to this essay on the shaking palsy, you know, James Parkinson was quite accurate about talking about, you know, the tremors, propensity to bend forwards at the trunk, to pass from a walking to a running pace. Really, the only thing that I say that he was not very accurate about, and you can't blame him, because this is over 200 years ago, was this part: the senses and intellects being uninjured. And of course, we know that Parkinson's is a multimodal, multi-system condition, and that it can result in a number of what we call non-motor symptoms of Parkinson's. Now, this was a survey that was published in 2020 that looked at their Parkinson's symptoms and their association with different quality of life measures. And we can see here that if you look at this graph here and try to categorize between the motor symptoms such as tremor, slowness, stiffness, versus the non-motor symptoms, the symptoms that are associated with the worst quality of life are actually the non-motor symptoms. So confusion, depression, hallucinations, memory loss, and anxiety. And I would say that, unfortunately, the non-motor symptoms are the hardest to treat. So we tend to spend less amount of time on these and focus more on how to optimize their motor symptoms, even though from a patient perspective, it's the non-motor symptoms that are more disabling. So case number 5, we have a 72-year-old male with Parkinson's taking carbidopa, levodopa, and rasagiline, who comes to clinic with his wife. The wife tells you he's becoming more isolated, more irritable, sleeping less at night, getting very angry at her over little things. He does not want to spend time with his friends or family or go to his favorite bar anymore. He seems to have lost interest in things he used to find enjoyable. So this is the case of someone that may have clinical depression. Depression is very common in neurodegenerative disorders. It's common even before the motor manifestations. So people with depression are at increased risk of developing Huntington's disease if it's genetic, or Parkinson's. But after the diagnosis, depression is very common. Here are some numbers. So about half of people experience some form of clinically significant depression, 17% with major depression and 22% with minor depression. It's important to try to distinguish between depression from apathy. And sometimes they can coexist between the two. So depression is what I would consider anhedonia, or lack of pleasure. Whereas apathy, they're just not motivated. They, let's say they like to go fishing before. They're like, oh, I don't want to go fishing. But if you really drag them out and you see that they enjoy themselves while fishing, it's probably not depression, maybe more apathy. But again, sometimes it's hard to distinguish between the two. There are different screening tests that one can do in clinic. I'm not a psychiatrist, so I won't tell you all the difference between these different screening tests, but there's a number. One is the Beck Depression Inventory, and you get a score, and that can tell you whether or not there's perhaps evidence of depression or not. This was a kind of a meta-analysis that looked at various non-motor treatments for Parkinson's. I think it's fairly common for many providers to consider using a SSRI, although you can see here that for all the SSRIs, there's insufficient evidence that is actually helpful. Probably the one class of medication that's shown to be potentially efficacious is a SNRI, or venlafaxine. But sometimes the depression is challenging to treat. I will say personally, I found the use of, let's say, sertraline or escitalopram to be effective in treating not just the reduced mood, but sometimes the behavioral changes that accompany depression, such as irritability or agitation. So I often use these class of medications to treat those symptoms. Here's a 79-year-old gentleman with Parkinson's who's recorded during a sleep study. He's been having abnormal nighttime motor behaviors that his wife states started 10 years before he was diagnosed. So let me just reduce the volume here. And so right now he's sleeping. Now, the good thing about a sleep study is you can actually record which stage of sleep this person is. And I'm assuming this person is in REM sleep. So REM sleep is a state in which the mind is very active, but your body's paralyzed. So technically, if you're dreaming, you shouldn't be able to move during your dream. But during REM sleep behavior disorder, which this person has, oh, sorry. They start punching, or they could be talking in their sleep. These are pretty well-formed behaviors. Most of the time, unfortunately, is involving some type of punching or kicking because they're protecting loved ones in their dreams. And that can be very dangerous, of course, to the individual, but also to the bed partner. And sometimes the bed partner has to then move out to a different room because of potential risk for injury. So sleep disturbances, including REM sleep behavior disorder, is something that we encounter quite a bit. As we all know, insomnia is a problem not just with Parkinson's, but in people with non-Parkinson's. So there may be other non-neurological causes for insomnia. They may have medication side effects that kind of wires them. They may have underlying mental health disorders like depression or PTSD that complicates their sleep. They may have poor sleep hygiene. They sleep with the TV on, and when they wake up and they can't fall back asleep, they turn on the TV. So all these things can contribute to poor sleep. And as we all know, sleep is really important for brain health. And if we're not getting enough sleep, our brains are suffering. So the optimal amount of sleep is between 7 to 8 hours of sleep. Other sleep disturbances can include something like restless legs. And restless legs is a condition in which people describe this urge to move. They have this creepy crawly feeling in their legs. People may also have sleep apnea. I always want to make sure that I screen. You can do an Epworth sleepiness scale. You can do like a stopgap, I think is the screening for OSA. And even if the scores are not that high, if you have a high enough suspicion, I would encourage people to refer them for a sleep study. The treatment specifically for REM sleep behavior disorder includes making sure they're in a safe home environment. So not that they would be sleeping on the bunk bed, but let's say there's like dangerous, sharp objects around their bed, try to remove those. Melatonin is a very safe, can be effective treatment for people with mild sleep apnea, mild REM sleep behavior disorder. And probably the most specific treatment we have for REM sleep behavior disorder is using clonazepam. Unfortunately, as we all agree, that clonazepam all opens up their own can of worms in terms of side effects and complications. All right, I believe this is the last case. We have a 74-year-old female with familial Parkinson's disease. So she has a genetic mutation that results in moderate slowness and significant cognitive impairment, also known as dementia. The family's telling you she's having worsening hallucinations that are frightening to her, so they're bothering her. She's also having persecutory delusions that her children are out to get her. Children are also concerned about her physical safety as she's falling multiple times a day due to freezing and shuffling, because she's, moderate to severe Parkinson's. Her hands are getting more stiff and it's harder for her to use them. And they want to know, what can you do to help with all of the above? So she's demonstrating motor complications. She's demonstrating cognitive impairment and hallucinations. So in terms of medications, she's already on carbidopa, levodopa, 800 milligrams a day, and donepezil, which is a cholinesterase inhibitor that's used for the treatment of dementia. And we can see here she has significant mass facies. She has really slow movements on both sides. So one of the things that has been difficult to balance is the treatment and the prioritization of what we call motor symptoms and the behavioral symptoms. And they're almost in a way complete opposite of how we, when we think about Parkinson's disease and behavioral changes and or cognitive impairment. The psychosis that we see in people with Parkinson's disease is likely a result of multiple factors, the disease itself, as well as the presence of the medications used to treat the motor symptoms. So as you can imagine, if they're on high doses of carbidopa, levodopa, that levodopa is going to be converted to dopamine, which may activate not just the nigrostriatal pathways important for motor benefit, but it may also activate other dopaminergic pathways, such as the mesolimbic, that can result in increased delusions, hallucinations, and so forth. So that's kind of where you prioritize the motor. But on the flip side, if you focus on the behavioral, and let's say, well, okay, I'm going to give you haloperidol, not that you would, to block that dopamine, because it's a good treatment for psychosis. Problem with that is that it's going to block the effectiveness of dopamine that you're just trying to give with levodopa. So it's really hard sometimes to find a nice balance between motor symptoms and the non-motor symptoms. And oftentimes what I do is I ask the caregiver, spouse, and the patient, what do you want to prioritize? What's most bothersome for you? And as we saw in that graph with the quality of life measures, with the non-motor symptoms being the most impactful, the majority of individuals want to focus on the behavioral aspects and not so much the motor symptoms. Now, fortunately, in 2016, the FDA approved a new medication for the treatment of psychosis and Parkinson's disease, and this is pimavanserin. It's a non-selective serotonergic inverse agonist. It's a mouthful. But the important thing is that it has nothing to do with blocking dopamine. So whereas using quetiapine, which is an atypical antipsychotic, one of the mechanisms of action of quetiapine is to block dopaminergic receptors. So pimavanserin came out, approved for Parkinson's psychosis, and can be used to maybe have your cake and eat it too. You're able to treat the motor symptoms and also focus on the psychosis. Now, clinically effectiveness, there's debate about how well both quetiapine and Nuplazid works. There's an ongoing VA study that's comparing the effectiveness of both. So we'll see what that study outcome shows. So in summary, Parkinson's disease is and will increasingly have a huge impact on individuals with Parkinson's disease, spouses, and society. As we talked about the Parkinson's pandemic with an exponential increase in Parkinson's cases. The approach to Parkinson's disease should really be a multidisciplinary or multimodal approach. And we're looking at clinical care, so different care providers, right? Your personal network, as well as the individuals in the community. Of course, treatment with Parkinson's should focus on balancing benefit and side effects. I always ask, how much you have a tremor, you'd say the tremor is getting worse, but how much does that bother you? Some people say it doesn't bother me at all. Some people are the complete opposite. They don't want to have any symptoms of Parkinson's because they're, a TV personality, or that's just the way they are. So we always have to balance the side effects and the benefit. The medications for Parkinson's include medications for motor symptoms and non-motor symptoms, although I will say that the motor symptom medication treatments are more effective. All the treatments that we have are purely symptomatic. We're not doing anything to alter the course of the disease, unfortunately. We don't have, a medication like the disease-modifying therapy in Alzheimer's disease, what's that medication called? But it's the amyloid antibody. And then, again, going back to this multimodal approach, aducanumab is the medication for Alzheimer's. Involvement of a multidisciplinary specialty is key to the successful management of Parkinson's. So with that, I thank you for the time, and I'm happy to answer any questions.
This was just excellent, Dr. Kim, just really, really excellent. Appreciated all of the videos, which really illustrates your point. A question came up at the very beginning to ask about, just a minute here.
Is that about the prevalence and the
yeah, how did the data correlate or not to population growth and the prevalence question?
Yeah, I believe that when they did the prevalence estimates, that accounted for increase in the population. So despite the increase in population, the prevalence of not just Parkinson's disease, but Alzheimer's disease is going to increase exponentially. It's just that the rate of increase is going to be faster with Parkinson's compared to Alzheimer's disease, although the pure number of people with Alzheimer's is still going to be much higher than people with Parkinson's. Got it.
And you've been answering some of these questions. There was a question about further information about the nicotine agonist or antagonist. Is it is that medication addictive?
No, yeah. I mean, honestly, I don't have any personal experience. That medication is istradefylline. So like that's not so much the nicotine, but the caffeine receptor, the adenosine A2A receptor. Caffeine, of course, can be addicting as well. But I don't have any personal experience with that medication. I don't personally think it's that effective. One of the holy grails for treatment of Parkinson's is looking at non-dopaminergic ways to improve function. And istradefylline was thought to be kind of like a pseudo indirect way of not affecting the dopaminergic pathway. But unfortunately, you have to be on dopamine in order for that medication to be effective. So again, well, there's a lot of holy grails and goals for treatment of Parkinson's. One of the other ones is providing consistent release of dopamine into the brain. As some people may know, levodopa is a very short-acting medication. It only lasts 90 minutes in the system. So then you get this pulsatile stimulation that can lead to some of these motor complications. So people have tried to develop therapies that release dopamine more continuously. One of the, I didn't really talk about this, but there's something called Duopa, which is a pump that goes into the small intestine and provides continuous dopamine levodopa gel into the gut. But the problem with that is that, as you can imagine, with any devices or pumps, they're highly prone to failure and complications. So very, very few people are actually use the duopa, even though conceptually it's a very effective treatment for some of the motor complications. Right now, there's a clinical trial looking at subcutaneous delivery of levodopa. We can't deliver levodopa through a patch, so it has to be delivered subcutaneously through some type of pump as well. And there's an ongoing clinical trial looking at that.
So Justin was still interested in the nicotine issue or the components of cigarettes in relation to Parkinson's prevention. Is anyone investigating that at all?
I'm sure there is. I'm not well versed in that part of the literature, but I know, just from a relationship standpoint, as I mentioned, smoking is related to a reduced risk of Parkinson's, and people just don't know if it's the nicotine or the behavior that is protective. Like certain people describe like a Parkinson's personality, and is it people who are very safe or people who are more prone to addictive behaviors? Are those people at increased risk of developing Parkinson's or not? And I would say it's a little bit inconsistent in terms of what those studies have shown in terms of like a Parkinson's personality that puts people at risk. So yeah, I'm not familiar with the nicotine literature.
Karen was interested, there's a link between Parkinson's and chronic low vitamin D?
I think we tend to treat low D. I don't think there's a specific direct link between low vitamin D and Parkinson's disease directly. But if we do certainly check for vitamin D levels and try to optimize that as much as we can, and thinking about that more from a global sense as opposed to a direct impact of vitamin D on the dopaminergic pathways.
And then there was a question about some of these interventions that you've talked about, like the surgery. Are there certain treatment attempts, failures that need to happen before insurance will cover?
Yeah, so regarding deep brain stimulation, it's not like, surprisingly, you would think that it requires like a lot of rigorous documentation to prove that someone's tried and failed certain medications. It's not like that. I think, some people just cannot tolerate carbidopa, levodopa, and there's no way for them to try or tolerate any of these medications. At that point, we will refer them for deep brain stimulation, and the insurance companies are seldom ever going to give us any problems with getting that approved.
Is there a long-acting form of carbidopa, levodopa?
Yeah, there were a number of longer-acting carbidopa levodopas. One is called CR, control release, or SA, sustained action. Back in the early 2000s, I believe, there was a study that compared the ability of long-acting carbidopa levodopa to delay the onset of some of these motor complications. And you would think conceptually that it would, but it didn't. So there's something a lot more complex going on in terms of the development of some of these motor complications, but we probably tend not to use the long-acting initially. We may add it in the course to try to prolong benefit.
Okay, I don't think I see any other questions unless I'm missing something. Oh, one new message. Oh, just more thanks for an excellent seminar, Dr. Kim. Really appreciate this information. And everyone, appreciate your patience with the evaluation form. I've put the link in there. You can use that for this week's lecture as well as last week's lecture. You just need to go back in again, and you shouldn't get that message that says you've already completed this survey, with my apologies. And we will see you next week. Thanks so much, Dr. Kim.
Take care.